Hello, my name is Dr. Melanie Bourgeot. I'm a third-year pathology resident at Emory University, and welcome to my third video on adnexal tumors. As the title suggests, in this video I'll be discussing some adnexal tumors that are primarily composed of cells with pink, or if you're fancy, eosinophilic cytoplasm. Before I get started, I just wanted to remind everyone that the links to the whole slide images for the cases I'm about to present can be found in the video description. Case 1 is a shave biopsy of a nodule on the wrist of a 69-year-old male. At low power, I see a well-circumscribed dermal nodule with edematous stroma as well as prominent cystic change. I'd also like to point out that this kind of looks like a smiley face, which isn't important for diagnosis, but it is kind of cute. If we move to higher power, we can see that this lesion is composed of a population of uniform cells with eosinophilic cytoplasm. However, there are some areas that have clear cell change. These cells also appear to be forming glands, which vary from small and inconspicuous like these here, to markedly dilated and cystic, which is what this area is here. The adjacent stroma is edematous to hyalinized, and contains dilated capillaries and scattered inflammatory cells. This is an example of a hydranoma, a benign sweat gland tumor which is part of a family of sweat gland tumors called Acrospiromas. Acrospiromas are composed of a uniform population of small to medium-sized cells with bland nuclear features and pink cytoplasm, which are sometimes referred to as poroid cells. They can also sometimes look a bit squamoid or have clear cell change. For those who love correlation with normal histology, acrospiromas are named as such because they are thought to originate from the cells of the acrosyringium, which is the intraepidermal portion of the sweat duct. Sometimes ducts are easy to spot and have well-formed or cystically dilated glandular spaces. However, these findings can be a lot more subtle, with mainly vacuolated cells or smaller immature ducts. The duct lumens are lined by cells with brighter, more eosinophilic cytoplasm than the surrounding cells, which can be helpful in difficult cases. Another helpful feature is the stroma, which is often hyalinized to edematous with dilated capillaries. Acrospiromas can have eccrine or apocrine features, but as with other sweat gland tumors, this has no real significance. Acrospiromas are divided into different types based on their low-power appearance. Dr. Edward Bolton's modeling clay concept is a great way to approach these tumors, and I'll provide a link to that paper in the video description. Hydranoma and poroma are the most common acrospiromas. Hydranoma presents a well-circumscribed dermal nodule that can occur anywhere on the body. Compared to other acrospiromas, hydranomas more often have cystic change and clear cell change. In contrast, poroma is intraepidermal and pushes down to involve the dermis. The classic location for poroma is on the side or sole of the foot. The other two members of the Acrospiroma family are Hydroacanthoma simplex, which is intraepidermal, and dermal duct tumor, which consists of multiple small dermal nodules. Since these are less common, I unfortunately don't have any examples to show today. So far, I've only mentioned benign acrospiromas, but atypical and malignant forms can occur. These lesions can arise de novo or from a benign acrospiroma. Features concerning for malignancy include infiltrative and or deep growth, necrosis, pleomorphism, and 4 or more mitoses per 10 high-powered fields. To learn more about atypical and malignant acrospiromas, I've included a link to a review paper in the description. Case 2 is a shave biopsy of a verrucous papule on the nose of a 57-year-old male. At low power, you can see the epidermis is thickened and distended by a population of small pink cells. At the edges, there is peripheral palisading, and the basement membrane appears thickened. The architecture is vaguely papillomatous, and there looks to be a hair follicle associated with this lesion. At higher power, you can see the lesion is composed of a population of uniform, mostly pink cells with bland nuclear features. However, as you move out towards the periphery, the cells become clear and then basaloid in appearance. Lastly, the intervening stroma has dilated capillaries and scattered inflammatory cells. This is an example of a tricholemmoma, a benign follicular neoplasm, often presenting as one or more papules on the face of an adult. They can be associated with a hair follicle, which is true in this case as you can see here. Some think that this lesion represents a variant of verruca vulgaris, but studies thus far have been inconclusive. I've included a link to a couple of these papers in the video description if you'd like to learn more. Tricholemmomas are predominantly sporadic, but can be associated with Cowden syndrome, especially if the patient has a history of multiple tricholemmomas. The cells of tricholemoma are morphologically homologous to the outer root sheath of the hair follicle, which you can see for comparison here. Hair follicle anatomy is complicated, but it's not required to know which tumor corresponds to which part of the hair follicle. However, recognizing these features can be helpful. An important histologic variant is desmoplastic tricholemoma, which has areas composed of infiltrating cords of cells within a desmoplastic stroma. These areas are usually located in the center of the lesion and are surrounded by conventional tricholemoma. On small biopsies without an obvious conventional tricholemoma component, these features raise concern for an infiltrative basal cell carcinoma or squamous cell carcinoma. Despite this pitfall, the desmoplastic variant has no clinical significance compared to conventional tricholemoma. Like most adnexal neoplasms, there is a malignant counterpart, called tricholemmal carcinoma. These are very rare, but is something to be aware of if you start seeing atypical features in a tricholemoma. Before I end this video, I want to talk about how to tell the difference between an intraepidermal acrospiroma and a tricholemoma, since both are pink tumors that often have clear cell change. Duct formation is probably the most important thing to recognize, though it can be subtle in some cases. Immunohistochemistry for EMA or CEA can be used to highlight these areas. Tricholemmomas are follicular neoplasms, so they don't have duct formation. However, you may see squamous eddies or areas of abrupt, dense, pilar-type keratinization, which you would not see in an acrospiroma. Other helpful features include hyalinized to edematous stroma, which is more characteristic of acrospiroma. Meanwhile, peripheral palisading and a thickened basement membrane is more characteristic of tricholemoma. And that's all I have for now. Please like and subscribe and stay tuned for the next video. You can also check out my Twitter and Kiko accounts for more educational pathology content. Thanks for watching!